Thank you very much, Ari. So it gets a little overwhelming when you've been in the business for 30 years and it sort of all catches up to you. But I'm very happy to be talking here tonight. I think that the Prostate Cancer Network has been an immense source of support for patients and for doctors and for urologists. I think that you guys do an incredible job, and I have to say that you make our lives a lot easier, because the diagnosis of prostate cancer is a very frightening experience, and when you have people who've been through it who can reassure you and support you, it really makes a difference. And I think we know for some patients who have prostate cancer, it's a journey that goes on for sometimes 20 years. And I know I've been in practice 30 years, and I've had patients I've done radical prostatectomies on who have then required radiation 5 to 10 years later, and who've then required various anti-androgens and chemo, and the process goes on. So I'm lucky enough to see many of my patients who live through this and can attest to the fact that prostate cancer can be a devastating disease for some patients, but it can also be a chronic illness requiring much support. So the Prostate Cancer Network, man to man, do an incredible job of helping these patients and doctors through this process. So I've been very fortunate to be part of the Gail and Graham Wright Prostate Cancer Center. And I'm going to go through this new paradigm which we've developed at North York General Hospital, and we have been doing these transperineal prostate biopsies. Now, before I start the talk, I'd like those men in the audience who've had prostate biopsies who developed an infection to put up their hand. So we have about 40 people, and we have about 3 men who have put up their hands. And that's probably about right. We have an infection rate when we do transrectal biopsies of around 5 to 10%. I won't ask these men what the infections were like, but they are extremely debilitating. You can end up in the intensive care units with intravenous antibiotics. You have to be on them for a couple of weeks. Some patients don't feel right for 6 months after the biopsy, and so for 10 years, the Gail and Graham Wright Center has been trying to find a new way to do biopsies or to prevent infections, and I'm going to take you through our little ride through this development. So the Prostate Center is made up of an interdisciplinary team of urologists, radiation oncologists, nurse coordinators, case managers, radiologists, pathologists, and volunteers from the man-to-man group. And we also have very important clerical staff. So to take a little moment, if you have a look at the back row, if Colleen, Jana, and Bev could stand up, please. I think for those of you who've been to our Prostate Cancer Center, we could not do what we do without them. They are absolutely unbelievable. They are friendly, they are open, they will look after you, they will navigate for you, they will see you don't get lost in the cracks, and without them, our jobs would be extremely difficult. So the whole problem with prostate cancer were the wait times, and in 2003, Sunnybrook did a study where they looked at the time a patient is referred to the time their treatment is planned. And the average time was about 35 weeks, which, when you look at it, is quite a lot of time. It's about what? How many months is that? It's quite significant. So we really wanted to try and decrease this wait time, because for somebody to wait 35 weeks before they get treated is absolutely unacceptable. So at North York, when we got referrals from GPs, we made it our mandate to try and see them within a week. And we were able to see patients within 9 to 49 days. They would get a urology consult, and then we would schedule the biopsy anywhere from 10 to 37 days. The time from the biopsy to when patients got their results, we managed to cut down to 8 to 18 days, average 12 days. And then after they had the results, we then had a meeting with the urologist, the radiation oncologist, man-to-man person, and our nurse navigator. And this would usually take place 2 weeks to up to 52 days. But most of the restraints were because patients were going to Florida, or they had a holiday, or they couldn't make it. But if we really got patients in when we wanted them to come in, we could do the whole process in 6 weeks. On average, however, our first group of patients were seen and diagnosed in 12 weeks with a plan of action ready to go. So we had decreased this time from 35 weeks to 12 weeks, taking into account patients' desires to go to Florida and all the other things that get in the way. So we actually, I think, have done a pretty good job. Now, the prostate center really, we sort of depend on family doctors referring patients. And I think all of you in this room know that family doctors have undergone this brainwashing process where so-called advisory committees have suggested that PSA is a useless test and a DRE a useless examination. So we saw a dip in the number of referrals when these studies came out in the US and in Europe. But in actual fact, what then happened was the patients we did see had higher PSAs and more aggressive disease and were actually younger. So, you know, as urologists, we definitely do not ascribe to those two studies and continue to suggest to GPs very strongly that a PSA and a DRE are mandatory in men between the ages of 50 and 70. We would recommend that men who are high risk have their PSAs done from 40. So for urologists, nothing much has changed. Now, the prostate center became a one-site shopping experience. So we saw to it that patients had rapid access, and the anticipated wait time to the diagnosis was about 5 weeks. And we try to see these patients quickly. We try to biopsy them quickly, give them their results, and counsel them according to what treatment they would prefer. And we became the only model in the province that combined programs such as oncology, surgery, radiology, and pathology. And we were also the only program that crossed organizational boundaries. So we managed to combine Sunnybrook, the radiation oncology center, with North York General Hospital. We made a mandate that this would be a patient-focused experience and not a provider-focused. What does that mean? It means that we will ask you to come to the clinic when you are available, not when you want to see the urologist who saw you initially. So the only complaints we've had include, well, you know, I saw 3 or 4 urologists. I don't know who my urologist really is. And I think in a way, patients didn't realize that actually we're getting 3 or 4 different opinions, and we always gave them the option to choose the surgeon they wanted for their surgery or the radiation oncologist they wanted for the radiation. These are the people we depend on: Bev, Colleen, Jana, Aaron, who actually runs the place from an administrative point of view. This is Kim Chu, who was one of the first secretaries we had. You met at the desk by Colleen and Bev and Jana, and you are then interviewed by a generic urologist. And once the diagnosis is made, you will then see another generic urologist and, of course, our generic radiation oncologist, all very friendly people. So while we were doing these biopsies, there were a lot of articles coming out about transrectal biopsy infection rates. And it was very disturbing because these rates were on the increase. And they were considerably higher than a decade ago, and we were finding all these papers talking about the infection rates, and what we tried to do was develop a protocol for antibiotic use and give patients intravenous antibiotics when appropriate. So if you had been traveling and were on antibiotics and came from outside the country, or had some kind of antibiotic within the last 6 months, or if you had heart valves that were problematic or whatever, we would give you intravenous antibiotics. We would take careful histories. We would, in patients who were diabetic, give them intravenous antibiotics, and so on. Unfortunately, though, we continue to have these infections. So articles started coming out about these superbugs and the question, should we favor transperineal biopsies of the transrectal approach? And certainly, this study from Australia, which was published in the British Journal of Urology in 2013, suggested that maybe a transperineal biopsy should be done in all patients who require a prostate biopsy. And they discovered that there was a negligible rate of sepsis with transperineal biopsies. So we started taking these articles a little more seriously. And we wanted to see if transperineal biopsies were equivalent to transrectal biopsies, because we didn't want to miss cancers. And articles started coming out from, this one's from Italy, but articles started coming out saying that there was actually no difference. And in fact, maybe there was better sampling at the level of certain areas of the prostate where the transperineal approach could access the prostate better. Certainly, there was no significant difference between the transperineal and the transrectal biopsies. So we started seeing, is transperineal biopsy the future? And the problem really was, the limiting factors were the increased time it took. You had to undergo certain extra training. There were some financial constraints, and people were doing it under general anesthesia or high levels of sedation requiring an anesthesiologist. So that seemed to be the rate limiting factor. We needed to do it under a general anesthetic. But then our colleagues at Sunnybrook Hospital, who did brachytherapy, which is a seed therapy, started doing seed therapy under local anesthetic, and proposed that maybe transperineal biopsies could be done under local anesthetic alone. So we started combining all the information we had attained, and in March 2016, we got a steering committee together and made it a mandate that at North York General Hospital, we were going to start doing transperineal biopsies under local anesthetic starting in October. Actually, we said September, but we were off by a month. Anyway, Dr. Loblaw, who's a radiation oncologist at Sunnybrook, who does brachytherapy under local anesthetic, came and taught us the technique. We went into the literature and developed our own techniques, and some of us use a two-spot technique, some of us use a one-spot technique, but basically, even though the biopsy took a little bit longer, we found that we had better access to the tissue in front of the prostate, which we couldn't get with a transrectal biopsy. And we started looking at a comparative analysis comparing our lowest infection rate, which was 4%, and we started looking at our patients and looking at the data to see if what we had read in the literature played out in real life. So just to show you what we're talking about, for those of you who have never experienced a biopsy, we have the transrectal biopsy on the left. And what this involves is an ultrasound probe that goes into the rectum, and there's a needle guide on the ultrasound which goes into the prostate. But as you can see, the needle is going through the rectum. And even if we give you a fleet enema or a Dulcolax suppository or whatever, you have a zoo living in the rectum, whether you like it or not, and you're almost definitely going to get an infection if you go through the rectum. Of course, our infection rates are lower because we put patients on antibiotics before, but we are going through a very dirty place to try and get a biopsy of the prostate in the transrectal route. The transperineal route, we still have to use the probe in the rectum. Sorry guys, but we still have to use the ultrasound probe. But we freeze the skin, and the skin is between the testicles and the rectum. That's called the perineum, or I think one of my young nephews calls it a cooch. I'm not sure what the actual term is, but we basically freeze that whole area. And as you can see, whereas this one, you're going to get good biopsies from the back and very little from the front. In the transperineal biopsy, you can actually get really good biopsies from the front and the back. Not only that, but this area, the back part of the prostate, is the area where 90% of prostate cancers will originate. When you do a transrectal biopsy, you're just getting a little snippet of tissue because you're going right through. Whereas with the transperineal, you actually get a much larger swath of the biopsy going through the significant area. So how does this play out in real terms? So this is called stirrups, and this is our bed in our prostate center, and that's where we do our biopsies. To prepare patients for the biopsy, basically informed consent. We give them a Dulcolax suppository the night before. They have an oral antibiotic 2 hours before the biopsy, and this is just really to prevent a skin infection. If patients feel very anxious, we'll offer them some oral sedation, something to put under their tongue. They put in the dorsal lithotomy position. We clean the perineum with iodine. We then give them this local anesthetic. We insert the transrectal ultrasound, and then going through the perineum, we do our biopsies. Now, Adam, Dr. Tunis, is going to talk about all the sort of different types of biopsies and MRI and all that stuff. But basically, we decide whether they're going to have a targeted or a systematic or a combination. And then we tell them what to do afterwards. They're usually at the prostate center for about 2 to 3 hours. And when they are feeling okay, they then go home and see us 2 weeks later for the biopsy results. So what I'd like to do now is just present the data from North York General Hospital, because we took our first 416 patients and had a look at the data, because it's very important to always assess what you're doing. This was a retrospective study, so maybe not the best study, but we looked at our transrectal ultrasound biopsies from June 2007 to 2012, and we had analyzed these 5 years of data. And then we took a recent cohort from March 2015 to May 2016 and compared it to our transperineal biopsies from October 2016 to July 2017. And what did we find? So of the 416 patients biopsied, 200 of the biopsies were positive. That is a detection rate of 48%. 8 patients went into urinary retention, so they had to have a temporary catheter. There were 2 urinary tract infections. But what is important, we had no hospital admissions and no patients with urosepsis or septicemia. If we compare the transrectal versus the transperineal biopsies, the cancer detection rate in the transrectal group was 44%, and we looked at 3,152 biopsies in the transrectal group, and 1,387 had positive biopsies. In our transperineal group, 200 out of 416. So actually the cancer detection rate was 4% higher in our transperineal group. One of the things we want to see is, are we picking up more high-grade tumors? And as you can see, Gleason 6, 7, 8 to 10, these are our low-risk, intermediate risk, and high-risk patients. The figures were very similar. In fact, we picked up 40% Gleason 6s in the transrectal, 38% in the transperineal, 48.6% Gleason 7s transrectal, 51% transperineal, and about 11% in both the transrectal and transperineal groups of the higher grade cancers. So this really showed us that both the transrectal and transperineal biopsies were equivalent, but our detection rates were higher in the transperineal group. Complication rates. So if we look at ER visits for our transrectal ultrasound biopsies, about 5.3% of our patients ended up in the emergency for either infection or bleeding, and there was about a 2.5% admission rate, whereas with our transperineal biopsies, 8 patients needed a temporary catheter, but there were no hospital admissions for infections, and the overall complication rate was much lower. Bleeding with the transrectal technique often comes from the rectum because of hemorrhoids, whereas with the transperineal technique, we don't see rectal bleeding, which can be quite a significant complication. What are the conclusions? And basically, we feel that we can pick up tumors in the front of the prostate better with the transperineal technique. We get more tissue from the peripheral zones because of the angle the needle goes into the prostate. We have higher detection rates of prostate cancer and a lower risk of complications. And we've developed a technique where this transperineal biopsy can be done under local anesthesia in a clinical setting, just as we do the transrectal biopsies. And so we continue to do our transperineal biopsies. The only drawback is we are now an extremely popular prostate center where everybody wants their biopsy done transperineally, and our waiting list has gone from 1 to 2 weeks to 4 to 6 weeks. And we're begging our administrators to give us more time to do more biopsies so we can get patients seen quicker, diagnosed quicker, and get them treated if they need treatment, and watch them if they need watching, whatever the outcome is. Thank you very much, and I'm going to hand over to Adam now.
Okay, so I'm going to talk a little bit about prostate MRI tonight. And just a question, who here has had a prostate MR as part of their investigation? A couple of you, okay. So prostate MR is a growing field in the management of prostate cancer and workup. Closer? Yeah, sorry, I don't think this one's working. And it's something that we have been working on implementing at North York General Hospital for about a year now. So just a brief background, MRI uses a very powerful magnet, usually between what we call 1.5 to 3 Teslas. And just for a reference range, it's about 1,000 times more powerful than the Earth's magnetic field. And it uses this magnet in combination with radio frequency waves, the same waves that an AM radio uses to image your patients. So it's a very safe and non-invasive way to image patients. A lot of MRI, especially in the prostate, we also use an IV contrast that injects it, makes the pictures come out a little bit clearer and gives us more information about the tissues. So the big benefits of MRI is that it doesn't use any radiation, so there's no ionizing radiation. So it is a very safe way to image patients as compared to CT or nuclear medicine examination. It's non-invasive, so when you compare it to the alternative of having a biopsy or surgery to come up with a diagnosis, MRI is a non-invasive and very easy to tolerate procedure. And it provides very exquisite soft tissue contrast and resolution so that it gives us a lot of detail about the tissues and allows us to pick up disease processes occurring at a very early stage. Some of the drawbacks of MRI is that it happens in a small, what we call a bore, a tunnel. You can sort of see it in the picture here, but anybody who's had the MRI know it's a small hole. It's about 2 feet in diameter, 2 to 3 feet in diameter, and it's quite long, so that for people who do experience claustrophobia, it can be a bit of an issue of that. There's a small risk of an allergic reaction to the IV contrast. And the other big drawback of MRI is that the scan time, it depends on how much contrast we want out of the pictures and how much resolution we want out of the pictures. So it's the same as taking pictures with a camera. The resolution is like the number of pixels on your digital camera, and the contrast is sort of how bright and how clear your pictures come out. And so to get better pictures, we need to scan people for longer. So for some exams and prostate MR, we're talking scan times of close to 45 minutes in the tunnel, which can be quite a significant amount of time to be lying still for a patient. Now, when we talk about prostate MRI, the hot topic these days is what is called multiparametric MRI, and this is usually performed with a 3 Tesla magnet. And basically multiparametric is a fancy word to say MRI looking at 3 different parameters. And the 3 parameters that are used in the prostate is what we call T2, which is basically a measure of how much water or fluid is in the prostate or in a lesion. Diffusion, which is a measure of how many cells and how closely packed together those cells are. And the contrast enhancement, or blood flow in a lesion. And basically prostate MRI, about 10, 15 years ago, sort of the early 2000s, there was a lot of basic work on the sort of basic premise of this. A lot of it actually came out of Sunnybrook originally. And the initial studies showed very good correlation between Gleason 7+ prostate cancer, so basically the intermediate to higher risk prostate cancer, and prostate MRI. The downside of this is that this was all done in a research setting. And you can see here, this is some of the literature out of Sunnybrook originally back in 2011. And this here is a sample from a prostatectomy. And you can see here, there's a little tumor here. It's really hard to make out. I know some of the MR images sort of look like ink blot tests to non-radiologists. The slides with the cells, they sort of look like shades of purple to me. I don't really see it, but according to the pathologists, there is a small tumor here. And then when we look at the MR, this little black spot here on the T2 where there's not much water, this black spot on the diffusion where there's a lot of cells packed really tightly together, and then this bright spot on the contrast enhancement where there's a lot of blood flow corresponds to this tumor. So we can see that all these 3 things fit very nicely with what we see in prostatectomy specimens. And in a research point of view, it works really well. But when it came to clinical practice, there was some lacking and a lot of variability that made this a difficult test to implement. So in 2014, the American College of Radiology came up with this guideline called PIRADS, which stands for Prostate Information Reporting and Diagnostic System. And basically it's a guideline that is intended to help standardize the reporting of prostate MRI across all practices, from large academic practices to small community practices. And the big difference with this compared to prior attempts was that this is really designed for clinical applications. It wasn't a research tool. This is designed to be implemented and have a clinical impact. And basically it's a 5-point scale from 1 to 5. And if you get a score of 1 or 2, it's basically supposed to be benign. So very high probability that this is benign and there's no cancer in the prostate. A score of 3 is indeterminate. It's when statistically it almost works out to a coin toss at that point. And then 4 or 5 is a very high probability of malignancy in the prostate. And it's based on all 3 of the MR parameters that I talked about earlier, the diffusion, or DWI, the T2, and the contrast enhancement. And now this came out in 2014, which was just when I was finishing up my fellowship down at St. Mike's. And St. Mike's had a very busy prostate MR practice, so we thought we could take a look at this new tool and apply it to our practice and see how it worked in real life. And we had very good results, as did many groups across North America. And just a brief highlight, you can see most of our cases, this was a study of about 200 cases, most of them came in with scores of 1 or 2, so basically no cancer, and then a very similar spread of disease between 3, 4, and 5. And when we talk about a diagnostic test, we often talk about what we call sensitivity and specificity. And basically sensitivity is the ability of a test to rule out disease, or rule out cancer in this case. And in this case, the sensitivity really matters for when you have a score of 1, 2, or 3, where basically the test is saying, we don't think there's disease here. And with prostate MR, in this test, and this is from our results down at St. Mike's, but these were replicated in many groups across North America, that a 1, 2, or 3 score has a very high sensitivity of about between 90 to 100% to say there is no cancer in the prostate gland. So that's a very reassuring result, that despite what your PSA is, if you come up with this score, it's very likely that there's actually no abnormal cells in the prostate gland, or at least no high-grade disease. And then the specificity, or our ability to confirm cancer and say this is something that needs to be chased further, This is where we're talking about the 4 or 5 is where we want to look at those. And at a score of 4, we're saying it's about 60 to 70% risk of having cancer in the prostate. And when we get up to a score of 5, we're saying it's 75, and some of the more recent results say that high score is actually even higher, closer to 80, maybe even 90% risk of cancer in the prostate. So taking a step from a sort of more academic research application up to North York General here in a community practice, when I first came here, we only have 2 1.5 Tesla magnets. We don't have a 3 Tesla high field magnet, so it was very limiting. But speaking to the urologists here, there was a real need to get some ability to perform prostate MR at North York General. I don't know, those of you who did have an MR, you would know that the wait times in Ontario, unfortunately, are not always great. Most people are waiting at least 1 to 2 months, but some of the academic centers, the wait lists are getting up to 6, 7, or 8 months for MRI wait. So we obviously want to shorten that, and also being able to provide a service closer to home so that you can be performed all within one hospital and avoid transiting between different centers. So we were fortunate that we don't have a high field magnet. In 2015, we had a major upgrade of one of our magnets. And while we didn't get a bigger field, we got sort of better antennas and better signal processing that allowed us to get better images out of the prostate in particular, although it has applications across the whole body. And this allowed us to start up a prostate cancer or prostate MR program, which we've been running now for just over a year at North York General, and we've done about 200 MRIs. So just to give you an example and show sort of the benefit of this, this is a case that came in about 6 months ago, a 56-year-old with a rising PSA that was now up to 30. And those of you, many of you here I'm sure have an idea of this, but this is probably about at least 5 to 6 times normal PSA result. He'd had 2 prior biopsies, both with the transrectal approach as well as one with the newer transperineal approach that Dr. Flax was talking about earlier. Both of those had come back negative, but his PSA was still climbing, and there's sort of a high suspicion. So he came in and had an MR, and you can see here on his MRI we have the diffusion here. We see a little black spot, saying there's lots of cells. You can see it doesn't show up quite as well on this screen, but it's also dark on the T2. And these are sort of axial images across the prostate, and then this is a vertical slice through the prostate here, and you can see the same small lesion there. And then post-contrast, you see this little thing lighting up here. So there's a lot of blood flow in this lesion. And so this is a high suspicion lesion, and this lesion is only about 11 millimeters, so just over a centimeter. So it's very small, which means that it comes up with a score of 4, not a score of 5. But the fact that it meets all of these criteria means that it's a high suspicion lesion. This gentleman went on to have a 3rd transperineal biopsy with sort of extra samples performed of this left side of the gland, in the high gland. And as Stan was saying earlier, this is one of the areas that with the transrectal route is harder to reach. Because if you can see here, this is the rectum down here. And if we were coming from the transrectal route, you have to go through about over half the gland before you get to this little tumor. So this would be one of the lesions that we would often miss on a transrectal biopsy. But with a repeat targeted biopsy, we did get a sample from this lesion, and it did turn out to be a Gleason 7 tumor, so an intermediate risk cancer. So that's sort of the big benefit of MR, is that we can find these smaller lesions, and it allows us to guide this biopsies and get a diagnosis early when we have very small and hopefully sort of lower risk cancer in the sort of Gleason 6 or 7 stage. Some of the future things that we're working on developing at North York General is, and we're very hopefully going to develop soon or enable soon, is doing an MR fusion biopsy. And what this allows us to do is take, instead of just looking at the MR images and saying, we know it's in the left side of the gland, so we're going to do extra passes with the needle there, it allows us to fuse the 2 images together, sort of like, almost like a virtual reality fusion, and you can do a pinpointed guided biopsy right of the small lesion. This allows us to get a more accurate sample of the lesion and hopefully give you a more accurate diagnosis and increase our biopsy yield, as well as decrease the number of biopsies we have to do. So for those of you who have gone through prostate biopsies, whether you had a transrectal or transperineal approach, usually we're doing between 12 and 14 biopsies, and everybody here they're counting down the clicks as we take each pass. So if we can decrease the number of clicks, it means you're in the room for less time and fewer needles, and overall an easier and safer procedure. And then some of the other things that we would hopefully like to implement in the sort of longer term is doing the sort of automated detection of these lesions and characterization, which is some additional software packages that are available. And hopefully at some point we will also be able to get a 3 Tesla MRI at North York General, which will improve the image quality that we get. And the better image quality, basically, you're able to pick up these lesions when they're smaller and more subtle. And that all corresponds to sort of earlier stage and lower risk disease, so which enables you to get patients into the system faster and come to a diagnosis faster. I'd like to thank you guys for your attention, and thank you, Ari, and everybody for organizing this tonight. And I think Dr. Flax is still here if anybody has any questions.